chatting. So we will go ahead and have Nestor hop on and share his screen.
Okay, thank you. Everybody hear me well, I hope. Let me quickly just press some buttons and we'll get going. And thank you to the Indiana Society of Neurodiagnostic Technologists and Technicians. This is current developments in motor evoked potentials, and I'm Nestor Nicolaides, the Director of Clinical Competency and Proficiency at NeuroAlert. I also do not have any conflicts for giving this presentation. So my objectives for this talk is to overview the anatomy of transcranial motor evoked potentials and have an overview understanding of what crossover is as it relates to a craniotomy, especially supratentorial craniotomy. I'm going to have a little focus on D-wave recordings, and right after they map the dorsal columns, as Chris just finished presenting, then we go ahead and then we can run some, well, actually before, but as the surgery is going on and they're resecting this intramedullary tumor, that we are able to protect the spinal cord and really the cortical spinal tract with D-wave recordings. We're also going to talk about cortical and subcortical mapping and also brainstem nerve nuclei mapping. And then a short literature review of short trend technique, which seems to be more the dominant and the newer kind of approach that's working. And and after this lecture, please feel free to contact me with any questions or any information or anything you want me to share at my email, which is listed here below. All these topics are easily an hour presentation, which in the past, Chris or I have given for NeuroAlert or for ASNM or whatever we're doing it. So this is going to be a quick overview. I'm not going to go into how. I just wanted to show you what cool ways we are using motor evoked potentials in the OR, more than just the common spinal cases. We use them for many other more increasingly risky surgeries, and we use motor evoked potentials to be more preventatory than predictory. And this is something I talk about very often in my lectures, because we want to be able to predict that, okay, if we're in this path, just like that carotid endarterectomy that Chris showed, that if we're in this path and we leave that brain not perfused, that this patient's going to wake up with a bad outcome. So we use these techniques to try to prevent it, not to say, okay, listen, we lost motors and let's expect a bad outcome at the end. Motor evoked potentials are a modality that we use in the OR. We stimulate with electrodes on the scalp, and we record in the muscles in the extremities. And here's a little diagram of how it works. Again, very similar to what Chris was talking about. We have the motor cortex and the sensory cortex, one in the frontal lobe, one in the anterior aspect of the parietal lobe, area 6 and area 4 respectively. And we stimulate, we put stimulating electrodes up in the scalp here on the right side of the scalp, and we stimulate and we activate the the cortical spinal tract here, lateral aspect more hands, medial aspect more of the lower extremities, which corresponds exactly as Chris was talking about before with the sensory cortex. This electric stimulation excites the cortical spinal tract. It now switches to the other side here at the pyramids of decussation and gets down into the spinal cord, and it causes the upper motor neuron then synapses with the lower motor neuron at something called the alpha motor neuron, and it takes something called temporal summation, and this is why we do need a multi-pulse train to actually temporally summate this response at the alpha motor neuron from exciting the nerve roots that go into the terminating branch, which then will assign the corresponding muscle in a compound motor action potential, which we see on our screen. Here's an example of where we would normally stimulate on a spine case between C2 and C4, between C1 and C3, using the 10-20 system. And please mark, if you're in the OR, mark and measure the head. Also with the EEG component of this lecture, they always mark and measure the head, and the reason is because accurate placement does prevent a lot of false negatives and false positive outcomes. All right, so again, this is an example of where we're trying to stimulate the motor and the sensory cortex. And these are responses we get. As you can see, they're kind of time locked, right? So this is the hands that we're seeing a response here. And this is the lower extremity. And you see one comes after the other because of the way it's kind of correlating the spinal cord. The hands are more cervical and upper part of the spinal cord. And the lower extremities are more in the lower part of the spinal cord, and it's a time-like response. We stimulate somewhere between 50 and 700 volts, and we adjust it. Here's a recording. We were stimulating from the between C1 and C3, now on the left side of the brain, and we're getting responses on the right muscles. And here's a beautiful selection. And the selection of these muscles depends on the objectives of the surgery, depends on the trajectory of the surgery and how we determine which ones we're going to use. And here's a quick video of someone getting on our team. I think this was a case that I recorded yesterday. So this is a patient who has a 71-year-old patient. And why is this not starting? Oh, it is starting. Okay. This is a 73-year-old patient. You see them getting, this is impedance. This green color means that the electrodes are well placed and not loose from the scalp or from the muscles, the intramuscular recordings. This is a 70-year-old patient, had a diagnosis of a compression of the spinal cord and a spontaneous epidural hematoma. It extended from C2 to T3. First, they did a laminectomy. Patient was quadriparesis but it was improving slightly since then. And now they plan for an anterior and a posterior compression. And here you watch the technologist in the room. They're stimulating at 7. He started at 60 volts and quickly went up to 220, then 260 to get a response here on the left side of the body from stimulating on the right side of the brain. And then we're just going to move a little bit forward here. And now he's stimulating the right motor evoked potentials by stimulating the left side of the brain and getting responses from the right muscles. So here he's moved it. He's starting at 160. They are at 7 trains. So it's a 7-train pulse with an ISI interpulse stimulus of 1 at a pulse width of 75. And here he's slowly going up on his this technologist, who happened to be a male in this instance, is going up to 240 volts. And as he proceeds, he continues to go. He's not getting a response here from the hand all the way down to the lower extremities on the right side. If you notice here, he has one recording for the left side, and that is to see if there's any crossover, and also a troubleshooting mechanism, as Chris was talking about with the SSCPs, the ipsilateral side of the stimulus to see if there is any sort of response. So he continues, then as he's continually stimulating, he's up now at 8 trains, so he's increasing his train pulse to get more, trying to create more temporal summation. He's up to 310 volts of stimulation, and as he proceeds here, he starts to go up to he starts to get a small response from the foot, and he optimizes it, and he saves his, and he sets his baselines. And then for the rest of the case, he compares those baselines to the, he compares the baselines to the most recent trace, and he compares them, and there's all different alert criterias. At NeuroAlert, we kind of use that 70 to 80 attenuation. So if a response decreases by 70 or 80% from its baseline, then we call that an alert. We alert the surgeon, and you'll see some examples of that later in this presentation. One of the troubleshooting mechanisms that was not used in that last case is something called the ISI, the intrapulse interval, or interstimulus interval, and he was at a 1.1, which is pretty much very close to this 900 really quick train frequency. And as we can see here in this diagram, with nothing other than the time between your train pulses changing, the responses are better in the upper extremity when you're at a high frequency, and better in the lower extremity at a low frequency. And in that last example video that I just showed, it would have been beneficial to maybe try to increase the interstimulus interval to improve those signals and get the best baselines you can. So now let's move over to what is crossover. And crossover is a determination to see if our stimulation might be stimulating below a surgical site. So here is the same exact diagram. We're stimulating the right side of the brain to get responses from the left upper and lower extremities. And here is a mass sitting right here supratentorally on the cortex. And if we stimulate here and we excite these cells, we might be giving the surgeon a good information of how the motor function is acting in the brain during the resection of this tumor. But if we stimulate here on the left side of the brain, on the right side of the brain, and we get right side muscle innervation, the idea is that we've stimulated to high enough intensity that the current, which is going from anodal stimulation here to cathodal stimulation here, is so great that it's gone down to the internal capsule and has activated both the left and the right cortical spinal tract that goes down to the left and right extremities. And that is not giving the surgeon any information about what's going on here. We call this stimulating below the surgical site, and it can cause some what we call a false negative, which means that, hey, surgeon, we have at the end of the case, our motors are consistent with our baselines, and the patient wakes up with a significant motor deficit, and that's because we are not giving them proper information because we were stimulating too much. Even the absence of crossover and only getting one side doesn't necessarily mean you're not stimulating below the surgical sites. So we have moved to to other means. And also when we do in the OR, we're not only doing SSEP, we're not only doing motors or MEPs, we are also doing SSEPs, we're watching EEG. There's many aspects of, we call that multi-mode modalities. We're doing multi-modes to try to protect the patient the best we can with as much information as we can. So here's an example of and here we are, and here's a beautiful one triggered stimulus. It was a 3-train with an ISI of 2, a pulse width of 75 or 50, and the technologist here was able to go from left deltoid all the way down to left foot, left AH, with beautiful responses, but actually no crossover responses seen in the right side, which is telling the surgeon that we are perhaps stimulating and getting you really good information of the supratentorial region where that tumor is laying. So now let's switch over to cortical mapping and direct cortical MEPs and subcortical mapping and a quick literature review. And as I talked about before, there's the monopolar fast train technique, which has now become a little bit more prevalent in the OR and more commonly used by most in-house intraoperative monitoring groups, and also some of these external groups, traveling groups that Chris and I are both part of. So the old technique was this Penfield method, this bipolar long train, and it has been kind of determined that there's less seizures and more effective the short train method. In Children's Nervous System 2020, one of the most recent articles, Dr. Roth and his colleagues had went through 57 pediatric supratentorial surgeries, and on 39 of those, they were able to do bipolar Penfield, the older method, and then the newer method, the fast short train technique. And they were able to, on 39 cases, there was successful mapping on 34 of the cases using the newer soft train technique, and there was only 10 of 39 or 25% cases were successfully mapped the brain using the Penfield method. So it seems to be a much more effective and much safer for the patient to lessen seizure activity. I was showing you a case even using this short train technique where we were doing direct cortical mapping, really of the vocalis and the tongue. But when we were doing that, we did have a seizure, and I'll show you a example of that. And also subcortically, the literature is kind of going back to this short train technique, and it's in its multiple literature is also mentioning that 1 milliamp of intensity of stimulus is giving the surgeon a idea that it's 1 millimeter from the cortical spinal tract. So if you're getting a response at 9 milliamps, you are about 9 millimeters away from the cortical spinal tract as we're going. So even though we have tectometry, we have MRIs that are being used, and we can see it as soon as the bone flap is removed, as soon as the dura is open, as soon as the tumor is beginning to be resected or debulked, the anatomy shifts. So what they did in different studies, and here this is from the book of Neurophysiology in Neurosurgery, A Modern Approach, which was edited by Dr. Delitas Shills and Dr. Sala. There was 4 or 5, or actually here we are at 7 articles that they were discussed of how that this 1 millimeter per 1 milliampere was a viable technique. And they did in multiple ways, including intraoperative ultrasound, post-op MRI, and even intraoperative MRI and tractometry. Those seems to be the way we do it. And this slide, very familiar. This is one that Chris just had on his. Before you do direct cortical motor evoked potentials, which is we take this strip, we do our phase reversal again to identify the frontal lobe, area 6, and the somatosensory lobe, which is area 4. And then this is the same exact pictures as Chris had before. We put the strip across, the epidural strip. And here, as we see the responses here in 6 and 7, and here in between 2 and 3, there is the phase reversal. That negative deflection that we see on those median SSEPs becomes a positive deflection. In this instance, you would use 7, this electrode, as your electrode that is anterior to the sulcus, and you have this nice triphasic waveform here and here. So you think that's right over the generator for the median nerve. So you would take this 7, you would stick it into your stimulator box, the lead that obviously comes off of this, leaving the strip on the brain, and you would then stimulate to get direct cortical motor evoked potentials from that location. And here's a quick video of on the same surgery of that happening. And if you remember that surgery earlier, the technologist had beautiful response without crossover, but as the case went on, crossover started to creep in, and that was probably because the brain started shifting. So the legitimacy or the efficacy of the motor evoked potentials might not have been not have been exactly what the surgeon would require on this. So we took that strip 7 and put it onto the brain, that electrode 7, put it onto the brain, and there we got this beautiful response. Hold on, let me pause it right there for a second. And well, we got that beautiful response. We set our baseline. We're able to follow that for the entire case, and the patient woke up with no deficits. And that response that we got there was only at 6 milliamps. It was 5 pulses with the space between it at a 4 millisecond interval, and the pulse width was 250 pulse width. And really, what this is even another article which I didn't even discuss here, but they just determined that the coaxial and the Cronax and the Rio base will intersect at a perfect point around 200 to 250 of a pulse width, and to give us our best responses. So we start with a pulse width of 200, we go from 1 milliamp to 25 milliamps. If we don't get a response, then we go to 250, 300, 350, up all the way up to 500 till we get a response when we're doing direct cortical mapping. So now I'm going to switch over to D waves, okay? And this is a quick sign. D waves are done for intramedullary tumors. We stick a spinal electrode above and below the surgical site. So say the surgical site is here. You're thinking they take a spinal electrode, put it above, rothally or proximal, and then they put one and put it below, which is distally, and they're able to see responses from the cortical spinal tract. So again, we're stimulating at the same spot on the scalp with scalp electrodes. Electrodes try to activate the cortical spinal tract, but in this instance, we record from the cortical spinal tract. There is no summation. There is no temporal summation at the alpha motor neuron. So we do this with just one pulse, and not that multi-pulse stim that we're commonly using. Here's a picture of us sliding it in. For the reason of time, and this is we can see here is a D wave. Here is I waves, which is a activation of the pyramidal neurons, not the pyramidal axons, which we see here on the D wave. Let's just skip that. And we have a different criteria for D wave outcomes. And here you see a D wave that does not change for the whole case, but we see some flexibility in the motors. So if there's no loss of patient motor function, this is the outcome. That means that, usually that corresponds to no alerts of muscle MEPs and no alerts of your D waves. Transient loss is when we alert our MEPs. There's more of a 70% change in our amplitude, or we've lost some, and but our D waves remain unchanged and not alerted. And that's usually just a transient loss of 2 or 3 weeks of some motor function, which does come back. Long-term, not term, changes in motor function we see with alerted and loss of our muscle MEPs, and we do see a 50% attenuation of our D wave amplitudes, and that usually relates in a long-term motor function loss. And then complete motor function loss is when we lose our MEPs and lose our D waves completely. So I'm going to show you a video. I hope these are beneficial. So here we are, and this was a 63-year-old with a tumor. Patient had weakness of the right hand down to the fingers, also some numbness. Now as time was going on, the bicep started to weaken, and there was some left leg weakness and during walking. So the electrodes are in. I constantly, especially a case like this, because it was C2, and you're really putting that proximal on the brainstem, you constantly check that impedance to see how those strip spinal electrodes are actually connected to the spinal cord. Sometimes you'll tell them to take a wet patty and put it on top. And here we are stimulating, and there we do, you see me, you press one side and the other side, we reverse polarities, and here these is representative of the proximal above the surgical site, somewhere probably close to the brainstem, and these responses here are distal to the tumor, to the intermedullary tumor, and we're able to see that the cortical spinal tract is still functioning above and below the tumor site. So the surgeon has just opened the dura, and we are setting our baselines here. So as the case then proceeded, as the case proceeds here, we're seeing that I'm notating that the debulk on the mass with bipolar, and you can see the artifact here of the bipolar being used to debulk. And we are seeing some attenuation of SSEPs. Surgeon is aware, and it's as he says is expected. Then we ran our, I don't know if anybody saw that, but we hear, and here if you're paying attention to this D wave screen, this is the upper, and there's a response, a beautiful response there again, above the surgical site and below the surgical site. So we proceeded. I was also during this case, you're constantly running SSCPs, you're constantly running motors. So the surgeon then we've been asking him to run motors for a while. One of the drawbacks, and I'm going to pause this for 1 second, one of the drawbacks with MEPs is that the patient does buck. So especially when they're working, there's patient motion. In a perfect world, I'd want to stimulate that brain on the right and see just the muscle activity on the left in small motions, but the whole body, especially muscles of the trunk, will be activated, and that will cause the patient to move, which could be very risky, especially when the surgeon is working in right on the spinal cord trying to remove a tumor. So we request that the surgeon will step away, move away from the patient, especially with the blade or with the bipolar. I run the motors, and then he goes back. So we were asking for a motor. We were not getting it for a little while as he was doing his work. And here, as we get to the right side, I just pressed the button. We got it, and we had a flat line response here on the right side for the muscles of the cervical spine that are representative of the cervical spine. And we're still getting a good foot and TA, but we were not getting a great response here. So first step I do is try to optimize the MEPs, and then we were unable to do it. I then alert the surgeon that MEP attenuation. I tell the surgeon, and I document it to my oversight physician, Dr. Elliott, and we tell them that we've lost our extremities, we are attenuated of our motor responses. We inform the surgeon, and the surgeon at that point acknowledges. So what do you do next, right? You quickly move over to your D waves again, and I press the button, and look at this response I get. I get a whole bunch of noise. So having experience doing D waves often, I then again check the impedance to see if they're connected to the if they're still in. I pretty much know the answer. I asked the surgeon, have you removed it? He said, yep, I'm removing I think we've gone far enough. I think this is about as much as we can go. I've removed the strip, and then I inform, here I have proof of that it's been removed, and I inform the surgeon. I inform the oversight physician. So I'm going to go through a couple of other ones. This is the technique for subcortical and cortical direct impulses. And here's an example of what I discussed before. This is the surgeon has a probe in his hand. We have and we're going to do anodal stimulation because this is cortical mapping. He really wanted to know where the vocalis and where the tongue was. He believed that this patient was elderly, had a little dementia, and would not be able to do awake language mapping. So where we were trying to arrest the ability for the patient to speak electronically by stimulation. So instead of doing that, he said, let's find where vocalis is and where tongue is on the sensory cortex, and I'll try to avoid that area while I am doing it, believing that that's probably closest related to our language initiation area of the spinal of the brain. So here is a response. We're getting a response from the right vocalis and the right tongue. Here is a picture of the response. At the same time, we had a 1x2 strip on the brain. We used one of them after we did a modified phase reversal. Then we used one of the strips to stimulate direct cortical motors, and we were getting beautiful responses here consistently. And we used the other one as an ECOG. As the case went on, he wanted to switch and go back and check out the vocalis muscle, which then we switched from our DC MEPs to direct cortical mapping. We got a response here at 11:44, but we also did elicit a seizure, and the seizure activity was quickly treated with phosphenatonin and cold saline. And at the end of the case, he actually went back and wanted to identify the responses. Another utilization of motor evoked potentials is identifying lower cranial nerves nuclei. This is a 5-year-old male, had a 1-year history of balance disturbances and trouble walking for 6 months. Unfortunately, the neurologist who was following did not send him for any imaging until about a year after these symptoms started, and they found this large mass somewhere located very close to the fourth ventricle. We know the fourth ventricle is there to create and store and return cerebrospinal fluid, very important part of our body. And if you look, here is a diagram of the fourth ventricle. And if you look here on this below diagram, here is the cranial nerve nuclei for the hypoglossal, and here's the cranial nerve nuclei for the vagus. So I put needles in the tongue, subdermal needles in the tongue, and also in the cricoid cartilage. The patient came in intubated, so we were unable to use electrodes that we put on the intratracheal tube. So I ended up just sticking them into vagus innervated muscles. And here we were getting a response at 0.5 milliamps. At this point, the surgeon said we're too close to the cranial nuclei, and he then aborted the rest of the resection of the tumor.
Nestor, I'm sorry, I hate to interrupt. We are past time, and I'd like for the audience to have an opportunity for questions and answers for you and Chris both, so we can bring on our new presenter, our next presenter. I apologize.
Sure, I think I blame it on Chris because he probably took too long.
I'll take the heavy for that.
I blame everything on Chris. So yeah, go ahead.
If this is an okay time. So thank you so much for presenting. That was great. Both of you guys were amazing, getting lots of positive feedback. So if anybody has any questions, you can feel free to unmute yourself and ask them to both presenters now. You can type it in the chat box if you don't feel comfortable sharing your video or unmuting or asking in front of everyone, either way.
Can you hear me?
Yes.
Yep. So Eric Isaacson, I know you're out there. You've had 2 pots of coffee, so hope everybody is awake. Okay, here we have a question. I'm sorry. Cricoid muscles with a question mark.
Yeah, that's cartilage. There's some muscles back there too, but that's where you place the electrodes for if you cannot use the intratracheal tube. When you do that, just a quick note is that do it with help of, be very experienced in placing them, and also do it with the help of the anesthesiologist. They should be holding the tube or where the tube is located, so you don't pierce that intratracheal tube and cause a slow leakage during the case. So you kind of do it together as a team.
Okay, thank you. We have another question. Based on the situation that one of our attendees had last week, could a CVA during surgery cause a loss of bilateral MEPs, but SSCPs remain intact? So right side MEPs did return after surgeon removed the implant, and this particular person didn't think CVA was the case, but surgeon thought it might have been. Can you respond to that?
Chris, why don't you answer that one?
Well, I mean, I just want to make sure we're on the same page if we could qualify what we're referring to as CVA.
So Kay Paget, if you want to unmute and you can go ahead and speak up, that would be great. You guys can have that interaction.
Okay. Hey, he just asked me after everything, he thought that the patient might have had a stroke is all he said. Mm-hmm. He didn't really clarify it anymore. And I didn't, I told him, right. So I didn't think so, but I wanted to see what y'all thought.
Well, certainly, without too great a dive into additional details, absolutely, you could absolutely have particularly embolic events that cause very specific impact to MEP versus SEP. The challenge that I present here is the bilateralness. That causes much greater complexity to the interpretation. The likelihood that it's a full-blown vascular event that would selectively cause bilateral change in either of those modalities is pretty low. The likelihood that there was some sort of vasospasm or vascular event that was specific to the spinal cord, that may be the case. That may be the case where you're, you've got specific vasculature. I shouldn't say specific because we're becoming less confident that you've got posterior spinal arteries that perfuse sensory and anterior spinal arteries that perfuse motor. There's a lot more overlap than we thought, but that could be the explanation, is that you have an anterior spinal artery issue with the posterior perfusion maintained, or vice versa.
Okay. Yeah, and he had placed a really large size implant. The loss was immediately after implant was placed. He
Mhm.
removed it and the right side returned immediately. The patient did wake up with left side deficit, but that has now recovered, but we're like 10 days
Yeah,
out.
yeah, it sounds like the likely explanation was right there at the level of spinal cord. And we, Nestor, you could probably comment on direct experience. We see a lot of specific events happening, MEP versus SEP, and often bilateral like that, because of stuff that's happening within that disc space or vertebral body space. Some of these events are reperfusion events where you've had this chronic compression. Now that you've taken that compression away, suddenly there's this reperfusion of the spinal cord that has a consequence of vasodilation or vasoconstriction, and you wind up with a change in function very rapidly. That could also be an explanation.
Yeah, rebound. A lot of sometimes rebound phenomenon is what Chris is referring to. Yeah.
Okay. Awesome. Thank you.
Great. Thank you for your questions. Anybody else have anything they want to ask? Okay. And I think that we're ready to move on. Thank you very much, Chris and Nestor. We appreciate your time.
Our pleasure.
Thank you.
Yep. Have a great day, guys. So we're going to let Lisa introduce our next speaker, Dr. Sokol. Thank you so much for your patience.